If we can get started, thank you all for coming. Today is the first of this academic season's Controversies in Cardiology. We're privileged to really have a fantastic program throughout the course of the year. For people who haven't joined us previously, the format is as follows. One of our cardiology fellows gives a brief summary of the subject, and then we have an interactive panel discussion, not a formal lecture, on the topic. And it's always been very lively, very, very worthwhile, and today's will be just as exciting as our past ones, if not better. I want to tell you a little bit about some of our educational content that we have in the next 2 months. On September 22nd, next Monday morning, 7:45 a.m., some of the institutions are going to be in on a broadcast. We have a panel discussion of stable coronary artery disease, which is going to be moderated by Dr. Sharma. October 20th, which is our next Controversies in Cardiology, on Dr. Pat O'Gara, with Dr. Pat O'Gara from the Brigham and President of the American College of Cardiology, and the topic will be on acute coronary syndromes. October 27th, we have a panel discussion led by Dr. Vivek Reddy on atrial fibrillation, and that's also 7:45 in the morning. Over the course of the year, we have once a month this Controversies in Cardiology. This program, as well as past programs, are archived on www.heart-talks.org. And you can see this one in a day or two, and past Controversies in Cardiology panel discussions. I think you'll enjoy them all. Today we're privileged to have Dr. William Deck from the Mass General. Dr. Fuster will introduce him more formally. Today's moderator is Dr. Mike Domansky. We're privileged to have him on our faculty. He's Professor of Medicine, Director of Heart Failure Research, Director of Inpatient Heart Failure Program, Chairman of the Cardiovascular Clinical Trials Oversight Committee, and he formerly had been Director of one of the clinical trial branches of NHLBI. We're lucky today to have an excellent presentation to start off our year of controversy. Dr. Ari Pollack is going to give us a summary on the topic of treatment and diagnosis of myocarditis.
Hi, everybody. For those who don't know me, my name is Ari. I'm one of the second-year cardiology fellows, and it's an honor to introduce the topic, and it's also been an honor to take Dr. Deck around today. According to the most current World Health Organization's classification of cardiomyopathies, myocarditis is clinically and pathologically defined as an inflammatory disease of the myocardium. It is diagnosed histologically as well as immunologically and with immunohistochemical criteria. Myocarditis often results from common viral infections that have a predilection towards entry into cardiac tissue. This event is typically followed by a maladaptive post-viral immune-mediated response, and with the development of PCR, the detection of enteroviruses, adenovirus, parvovirus, and human herpes virus in diseased myocardium has been made possible. Several other etiologies of myocarditis have been implicated as well, including HIV, Chagas disease, toxins, medications, along with autoimmune phenomena. In addition, myocarditis is associated with a significant amount of morbidity and mortality. It has been linked as the cause of sudden cardiac death in young adults in up to 12% of cases, as well as functioning as the etiology of dilated cardiomyopathy in up to 9% of patients. In medical practice, physicians rely upon a combination of clinical features, laboratory analysis, and non-invasive diagnostic findings to make the diagnosis. A definitive diagnosis, however, relies upon endomyocardial biopsy, an approach which is supported by the WHO as well as scientific statements made by the AHA and the European Society of Cardiology. Despite a clear definition and the well-established morbidity associated with this disease, many patients with clinical manifestations of myocarditis do not undergo endomyocardial biopsy, which, as I had mentioned, is the current gold standard for diagnosis. Why then, in the face of established standards, does there exist so much heterogeneity in the practice patterns of physicians as it relates to the evaluation, diagnosis, and treatment of this disease entity? Perhaps it's the wide variety of etiologies linked to the disease, along with the varied clinical presentations, that hampers patient identification and hasn't allowed for a real consensus in terms of the most appropriate diagnostic standards. The Dallas criteria, which relies on traditional histological stains, represents the initial attempt at standardizing diagnostic guidelines. It goes on to define myocarditis as either active or borderline, depending on the degree of inflammation and myocyte injury. There are legitimate concerns, however, about the diagnostic accuracy and sensitivity of the Dallas criteria, which may be explained by the focal and transient nature of the inflammatory process. As a result, endomyocardial biopsy with immunohistochemistry has gained further acceptance for diagnostic purposes. Questions linger, however, with regards to the need for routine biopsy, especially in light of the significant advances in imaging technology with cardiac MRI. Currently, comprehensive clinical practice guidelines specific to the treatment of myocarditis do not exist aside from standard pharmacological heart failure treatment for patients with symptoms and left ventricular systolic dysfunction. For patients with cardiogenic shock due to acute fulminant myocarditis who deteriorate despite optimal medical therapy, mechanical circulatory support may be required as a bridge to either recovery or heart transplantation. While specific types of autoimmune-related myocarditis, such as giant cell and cardiac sarcoid, respond to immunosuppressive therapy, tailored treatment strategies for viral myocarditis have yet to be established. Investigational treatment options inclusive of immunosuppressive, immunomodulatory, anti-inflammatory, and antiviral agents have been tested and reported in the literature with some promising results in specific patient populations. Ultimately, the diagnosis and management of patients with suspected viral myocarditis deviates significantly from practice guidelines. Multiple explanations have been offered, and I am certain that a few more will be entertained during this panel discussion. Questions that remain include: who should we send for an endomyocardial biopsy, and where should we obtain the tissue? How necessary is routine invasive diagnostics in an era of rapidly advancing non-invasive imaging techniques? Furthermore, what, if any, emerging therapy can we offer our patients? Thank you all very much, and I hope you enjoy the upcoming discussion.
Thank you very much, Ari. You look good, you look secure, your dressing is perfect. Very good introduction. Anyway, it is a pleasure today to actually introduce one of my best friends, Dr. Bill Deck. Dr. Deck actually was born in Washington, D.C., attended college at Georgetown University with summa cum laude, and then he obtained the MD degree at Johns Hopkins. He then moved in 1978 to the Mass General Hospital, where he had his internship in medicine, residency, cardiology, and certainly research at the same time, particularly during the training in cardiology. Now, he was in 1996, he became associate professor, and in 2005, he became the Roman DeSantis Professor of Medicine. You know, those of you who know Roman DeSantis is like a legend to all of us who had the opportunity to be at the Mass General. So this is a very good title to carry. Now, going back to some of his positions of Dr. Deck, we have, he became the medical director of cardiac failure, then subsequently medical director of cardiac failure and transplantation, and eventually became the medical director of heart failure transplantation fellowship training program. And then he kicked me out. He became chief of cardiology. Actually, he followed me at Mass General. Yeah, and we had actually great 3 or 4 years together before. So then became the Mass General Hospital Heart Center, where he has been co-director. Now, Bill has a lot of accomplishments, actually. In terms of committees, he has been on every conceivable committee, certainly in Boston and Harvard. Then internationally, he has been in the Thoracic Organ Committee to evaluate the artificial heart program at the National Heart and Blood Institute, the United Network for Organ Sharing. He was a very critical person in that organization. And then he was part of the Global Physician Network for Myocarditis Research, and so on. In terms of professional societies, all societies related to cardiac failure and transplantation, international, he's part of it. And then he became a member of the Cardiovascular Writing Committee of the exams, American Board of Internal Medicine. And then he's going to be the chair, I guess, next year of the board examination write-up of questions, a very tough task, actually, and for the American Board of Internal Medicine. Now, he has a very significant number of honors and awards. He started in college, Hopkins, Mass General. He got all the honors or awards that one can get, but it's of interest that he got the Partners, which is Mass General Brigham Award of Excellence for 5 consecutive years. They probably were tired of seeing you always every year there in getting that award. He got the Brian McGovern Memorial Teaching Award, a great friend of ours, Brian McGovern. Unfortunately, he died. And then he got the Harvard Medical School Prize for Excellence in Teaching in the 3rd and the 4th year. And so on. Then he Simon Duck Award for Outstanding Scholarship by the Journal of the American College of Cardiology. Now, he actually is working with us now as an associate editor of JACC. He has been in the editorial board of JACC for a number of years, and he's doing a fabulous job as a person who with tremendous dedication, consciousness, very deep into his judgments, and I think one of these people that is very well to know in terms of judgment, and certainly he's very involved with our JACC journal. Going back to publications, he has about 200 publications, over 200. I'm very curious, actually, the first one, 1976, volatility of 11 dinitroaniline herbicides, and appear in wheat Science. Would you a little bit out of...
Not that kind of weed.
No. Okay. I just wanted to be sure.
Chemistry major.
Anyway, he has published a lot, certainly in the topics that we have been discussing today. He gave a beautiful talk this morning on myocarditis, cardiomyopathy, dilated, restrictive, in all the aspects of diagnostic tools and therapeutic tools and the recent LVADs and so forth. He's fantastically well published. So it's a pleasure to have you here today, Bill, to share your time with the fellows. And now is a very special occasion, actually. Usually we give this plaque. We mentioned for outstanding teaching, wisdom, and expertise as the Anandi Sharma visiting professor, but we never know where his Anandi Sharma is, and today he's here. So, Mr. Sharma, wonderful to have you here. Who is the picture taken? Oh, please. You come here. This one.
You know better standing up, so you better like it.
I'd actually get a better camera.
Okay?
Thank you.
Wonderful. Thank you for being here with us and to contribute to the program. You want to say a few words?
Only a few words I want to say. Yes, sure. Okay. I am Anandilal Sharma. It's just by chance that I am here before all of you. I had been here just for a month and this date came in between. So I would like to thank you very much to all audience, all literate and very highly placed persons, and especially Dr. William Deck. I'm thankful, and you had given so much information to all of them that will benefit all of them, and their knowledge will be boosted up by yours. I thank you, all of you, and Mr. William Deck.
Good. All right, now comes the moment of the experts. We have asked Michael Domansky to be the moderator, and the panelists, Dr. Gopalan, Dr. Jagat Narula, Javier Sanz, and Ari Pollack. And Martin is giving me a rest. Bill, you go to the middle.
Right in the middle.
Okay, well, we certainly have a distinguished panel with a lot of expertise and a lot of diversity of expertise represented in the. So I'd like to start out. We have our imaging folks here today. I'd like to start out with a couple of imaging questions. So first of all, and Dr. Deck, I'll start, if I may, with you, and then the other panel members, Dr. Narula and others. What do you see as the role of MRI today in the workup of myocarditis? What expansion of the role do you see possible, and how do we get from here to there? I mean, what's the research agenda that takes us there?
Well, I think that this is a particularly important question as we move towards better assessing which patients actually have myocarditis. This had previously been largely a histologic diagnosis relying on endomyocardial biopsy or autopsy, which is not very practical. So having a non-invasive, highly reliable way to look for inflammation in the heart, typically due to myocarditis or other conditions like sarcoid, is extremely valuable for a clinician taking care of a patient with an unexplained cardiomyopathy. I think that currently, for patients that are being considered for myocarditis, if the clinical scenario fits, that probably the first diagnostic tool after echo and EKG would be a MRI done with gadolinium to go directly to a biopsy in a patient who is not in cardiogenic shock or severely compromised without at least looking at characterizing the myocardium in this day and age, I think, is probably not good medicine. I think that it's important to recognize that the current MRI includes T2 weighting, looking for edema, as well as early and late gadolinium uptake, looking for scar and necrosis, so that a complete evaluation would involve those three particular parameters done. And at that point, decisions can be made about whether the patient is likely to have edema or an acute problem, or may have a fair amount of scarring. So I think that in terms of my thinking about the MRI with enhancement, it helps to bifurcate, is this an acute process suggesting acute inflammation or not? And more importantly, even if this may not be myocarditis, the degree of late gadolinium enhancement tells us a lot about the prognosis of that patient, irregardless of etiology. So the more scar you see, the worse the prognosis, the lower bar I would have for considering them for transplant, putting in an ICD if necessary, et cetera. I think maybe before we talk about where it's going, we can let the other speakers comment on how they use it and then talk about the future.
Yeah, please.
Yeah, I agree with Dr. Deck's statements. I think that there are two roles for MRI currently in myocarditis. One of them is the diagnosis, the other one is establishing prognosis. And once we have the diagnosis, trying to figure out who's going to have more problems. So when we think about the accuracy of MRI, it depends on how we define really myocarditis, whether the accuracy is going to be higher or lower. So if we define myocarditis and talking about histological criteria of the presence of inflammation and necrosis, cell death, MRI performs pretty well. This is typically what we see in the acute phase when the patient presents with chest pain and positive troponins and normal coronaries. The MRI is extremely useful there, not only to see myocarditis if there is myocarditis, but also to differentiate from ischemic infarcts, which sometimes have normal coronaries, and we don't know simply clinically what they are. The second situation is when you have inflammation, but you don't have cell death. If you only have inflammation, T2-weighted imaging is something that we rely on, but it's also something that tends to be more susceptible to artifacts. So the performance of the technique starts to decrease. And when you define myocarditis only as the presence of the genetic material in the myocardium, as you can imagine, an MRI is not going to tell you that. So if you don't have inflammation, you don't have necrosis, the only thing you see is if you do CRP and you have an RNA or DNA from the virus, the MRI clearly does not perform well in those situations, which is more typically in chronic patients. So in terms of the diagnosis, acute phase particularly is most useful in the first few weeks. And in terms of the prognosis, the absence of late enhancement is associated with very good outcomes. So the amount of scar and particularly the absence of scar is an important factor that we look at also clinically.
Jagat?
Well, I think both Dr. Deck and Dr. Sands has explained pretty well. I mean, the clinical scenario as well as the imaging. I think the only thing I would like to say here or add to what they said was that we really need to do a lot more in terms of endomyocardial biopsies as well as their correlations with the CMR. The reason being that neither endomyocardial biopsy is perfect nor is the CMR perfect. You know, and we are comparing two things two imperfect things here. So I think the most important thing that we need to really do is, and actually the reason that I feel that the endomyocardial biopsies have disappeared from the field is because I think Dallas criteria has done the biggest disservice to this particular field. Our entire enthusiasm about doing the biopsies has gone away. And I would really want that the heart failure colleagues, you should be doing a lot more endomyocardial biopsies in the non-transplant cases so that we can learn about the disease. Sure, we know about the LL criteria when it comes to the myocarditis by CMR. We know what endomyocardial biopsies tell us, but we have not even scratched the surface here. We have not done anything about the treatment. One trial which recruited 1,000 patients but ended up with 111 at the end to tell us whether the immunosuppression is right or not, whether the antiviral therapy is to be used or not, anti-inflammatory therapies are to be used or not. I think there is a lot of work cut out for us. This is one condition which we learn early. We should be able to do much better in this particular field.
Bill, do you want to offer a spirited defense of the Dallas criteria, or am I not going to be able to get any rise out of you here?
It's really hard to defend something that's sort of past its time. But for those before we talk about biopsy stuff, which I agree with much of what Jagat just said in his impassioned way, to go back to your original question, which is what else would we need from CMR? I think closer histologic correlates with tissue we've heard about. I think the other issue is when I'm thinking about a patient who I should do a biopsy on, that T2 information about edema is very important. If I see a lot of that on the initial CMR, I'm much more inclined to think, okay, this is an acute process, particularly if the LV is not dilated on echo, and this is a relatively short duration of symptoms. But we've heard, that is not a completely reproducible measure. And so I would say going forward with our MR colleagues, if there are other agents or other techniques or, analyses that would allow us to more precisely quantify edema, or acute early injury as opposed to late scarring. The late gadolinium is terrific. We can't tell exactly what caused the problem or when, but we can quantify it and tell you how much is there. We need the same thing early on, because if all you see is late enhancement, the horse is probably out of the barn. I'm not sure that a biopsy is going to tell you very much in that situation. You want to see the person that has a lot of edema on their echo, or better, on MRI. So to move to the biopsy, since that was also raised, for those of you that are not myocarditis aficionados, the Dallas criteria were an attempt by cardiac pathologists to develop some histologic standard for making the diagnosis of myocarditis. Why? Because there were lots of controversies about it. Different people were writing about different things, and so in order to do multi-center trials, you have to have at least some entry criteria that are common among many different centers. And so the Dallas criteria were written in that one of the revolving restaurants somewhere in Dallas back in the early 80s, where they got a bunch of pathologists in there, hopefully before they had dinner and cocktails, to talk about what would be necessary. And they came up with really just two criteria. You had to have myocyte injury and necrosis and adjacent inflammation, typically lymphocytes, but could be other cells like eosinophils or giant cells. And if you had those two things, you had Dallas criteria myocarditis. The problem with that is that it was the histologic standard, and it was really not a gold standard, it was more a brass standard. It was very not reproducible. You could have panels of cardiologists, cardiac pathologists reading the same biopsy in a blinded fashion, and the inter-observer correlation was not much better than 0.5. I mean, it was really poor. And so there was not an agreement about even the most fundamental pathology that was being seen under the microscope. The second problem with making the diagnosis on biopsy is myocarditis is typically a focal or multifocal process. And similar to what we see with cardiac sarcoid, you can have granulomas in a lot of spots, but if your biotome doesn't go to those 3 or 4 spots, you're going to miss it. And the same thing is absolutely true with doing biopsies looking for myocarditis. There was a study by a guy named Houck and colleagues where he had some poor cardiology fellow or cardiac path fellow they had like, I think 30 or 28 hearts, explanted hearts from patients that had proven myocarditis, lymphocytic myocarditis at autopsy. And what he did is he had the fellow go through there and do biopsies to see how many biopsies you actually had to do in order to pick up myocarditis 100% of the time. And the number was 17.8 in order to not miss it in cases where it clearly existed. And typically we do 3 to 5 biopsies. So clearly sampling error misses a lot. And then my final point about this is that we've learned a lot that, I really think about this issue more of inflammatory heart disease rather than myocarditis, so that there's more things going on in the myocardium than just cells and myocyte injury. Typically, you see upregulation of HLA antigens, particularly DR antigen. You may see infiltrates of macrophages or T cells, and there's some criteria about that. There are immunohistochemical stains looking not only at the cells, but also for other things in the myocardium. There are cytokines, and now more recently, there's PCR looking for viral genome, and I'm sure we'll talk about that as we go into treatment. So the biopsy nowadays can tell you far more than just Dallas criteria, yes or no. And that's where I think we need to be going if we're going to go back and start doing more biopsies.
Can I just add one thing to that? 17.2 biopsies to make the diagnosis correct in 8 out of 10 times.
Okay. Right.
So that's so 17 times we perforate. So that's one. And the second important thing is that I would like to know your views on it, that the most important area where we need to make the diagnosis is the acutely decompensated heart failure when patients come in shock. And in that particular situation, if you look at the buttons that we take at the time or by putting the LVADs, you would see that there is no myocyte damage at that time. It's entirely, you would literally look at the biopsy, and you can just by gross examination of a biopsy, you'll be able to say it's all blue, because there are so many cells in there, but there is no myocyte damage. So essentially the most important time where we need to make a diagnosis, Dallas criteria does not fit.
Okay, thank you. We've sort of segued to biopsy, so I think we may want to finish that part of it. And I guess there are several other questions, and one of them is, how about right ventricular versus left ventricular biopsy? Bill, maybe we'll start with you, and then maybe work our way around.
So, I think it's pretty clear that in a process that's focal or multifocal, wherever your biopsy has a risk of sampling error, certainly the left ventricle is typically more affected by cardiomyopathy symptoms and heart failure earlier than the right ventricle in most cases. So it would make logical sense based on clinical presentation, if the left ventricle's down, the right ventricle's normal, you should biopsy the left ventricle, but obviously we don't. We biopsy the interventricular septum because it's safer. So there have been studies that have looked at doing right and left ventricular biopsies, showing that the yield is substantially higher if you do biventricular biopsy looking for lymphocytic myocarditis than if you just confine biopsy to the right ventricle. We actually did a study at Mass General, I don't know, probably 20 years ago, where we took, I think it was 25 patients that had negative right ventricular biopsies, but we felt so strongly that they had the disease that we brought them back and then did a second biopsy on the left side, and we picked up myocarditis in 20% of those patients. So just in our own very small experience, we were missing 20% of cases just with the right-sided biopsy. I think there have been some series that have published recently, we already comment on this, looking at several, like hundreds of patients doing biventricular biopsy, and the yield with biventricular biopsy using a somewhat more expanded definition that included immunohistochemical was more like 45, 50% if you do bi versus 30% if you just did right-sided biopsies alone.
I think the yield's actually higher. I think it's 60 to 70%.
So I think, you know, if we're going to really retool biopsies, doing it on the left side or both sides is probably the way to go. And in fact, the United States is rare. I mean, in Japan and most parts of Europe, they do left-sided biopsies almost exclusively. So we're kind of the exception.
You know, I want to finish this part of it just because I think it's really quite important. We do a lot of biopsies here. Most of them, of course, are on post-transplant patients. But you've talked a little bit about what we can get from those biopsies. Could you go down the list for us and tell us what we should be ordering specifically that's going to be helpful to us on those biopsies?
Sure.
Just production biopsies.
So, and Jagat, you can help me. Your wife's a cardiopathologist. So obviously you're going to want to get H&E and trichome stains just to look at general pathology. You're going to want to do immunohistochemistry, looking for different types of inflammatory cells, T cells, macrophages. You're going to want to do PCR, looking for a viral genome, and there's probably enterovirus, adenovirus, parvovirus, and some of the more common ones. You may do, if you can, you'd like to get a specimen for EM, looking for things like chloroquine toxicity and other infiltrative processes. Amyloid's usually not much of an issue. They stain for that, and that's usually a different population, so certainly that's a routine. Iron studies if appropriate, but I mean generally it's inflammation, necrosis, and then looking for viral genome. Do anything else that's...
I think you said it all, that most important would be to identify the areas where the electron microscopy could be helped. And as we were just discussing the new microscopy which has just emerged, what you call as D-STORM, or which is the direct stochastic optical reconstruction microscopy, which essentially, even by simple microscopy, gives you details which you might just be able to get by EM. So if you don't want to have an extra piece for EM, one could do the D-STORM microscopy. So,
okay, well, apart from the obvious structure and function that echo would give us, and we've talked about MR. The fact is, we've now talked about biopsy. Are there other imaging modalities that have some unique contribution to offer us? Jagat, do you want to start that, or?
I think Dr. Deck has done a lot, and I was his fellow when I used to do that, and then Dr. Kuster was there at that time when we did the entire imaging profile. So actually did a lot of anti-myosin antibody imaging with Dr. Deck. I think we published quite a lot on it. So that is the ways are to look at whatever the pathology that happens in the myocardium, whether we are able to identify that by the non-invasive techniques. So one possibility is looking at the myocardial damage. So we did the anti-myosin antibody imaging. And the most important publication was when we differentiated with the people who masquerade as acute myocardial infarction, but turn out to have myocarditis. And that was our NEJM paper at that time, and with Dr. Deck. And then after that, we looked at the HLA imaging, we looked at the leukocyte imaging, we looked at gallium-67 imaging. So we've done quite a lot, but I don't think that anything fits in as well as the CMR has given us. So I think if we have to go after anything at this point in time, CMR should be the way to go. And one thing which I would really like to add, and thanks to Dr. Fuster for that, because the MR PET machine that we have not been able to exploit the utility of that machine. I think there are some decent reports which are coming up now where you can do the MR PET, so have the CMR as well as the FTG, so that the inflammatory myocardial disease can be best identified when you have the combination of the two techniques. Yeah. Dr. Dick?
The other modality that I wanted to mention was the PET. I think for viral myocarditis it's unclear the role, but for sarcoid definitely has a role. There's mostly retrospective data but showing that when the inflammatory activity decreases in the myocardium with steroids, that's a sign of that the ventricular function, not so much the heart events, but the ventricular function is going to improve. So I think that's an area where more research is needed, and that PET will have a lot of potential in that particular subgroup.
Yeah, just a sort of an anecdote about that. We were talking about this afternoon. I have a patient that had presumptive cardiac sarcoid. She's a hospital nurse, worked in our telemetry unit, and she had a defibrillator, and I kept wanting to figure out whether she had cardiac sarcoid or not because her ejection fraction kept going down and she was having arrhythmias. So about 5 years ago, I just treated her empirically with steroids, which I really don't like to do because I didn't know the diagnosis, but she got better. So fine. So her ejection fraction normalized, her arrhythmias got better, her defibrillator quieted down. About a year and a half ago, it all came back, her ejection fraction dropped, started having some VT, and I still was fixated thinking about MR and how useful MR, but I was, can't do an MR, she's got a defibrillator. So she and I had a long discussion, and finally she said, well, why don't you just do a cardiac PET on me? I said, that's a brilliant idea. That's a great idea. And so we did it, and of course it lit up, and she was immunosuppressed, and she's coming back for a follow-up PET, although her ejection fraction's gotten better, so I suspect it'll be negative. So it's very useful for that kind of inflammation. Whether it will be for myocarditis, we don't know, because it hasn't been studied, but it could well be. I think one of the other questions that we were talking about, maybe it's on your list, but I think while we're talking about biopsy and MR, there have been groups in Europe, largely Marholt and others, that have advocated doing MR-directed endomyocardial biopsy. So you actually see where the inflammation is, see where the gadolinium is, and then try to get your biopsies close to that area, whether it be in the septum or the left side of the heart or the left ventricular apex. And although the Marholt data suggested that this was very effective in increasing the yield of myocarditis, subsequent studies have really not been able to confirm that. And I think that was your perception from your experience as well?
So there was an early report where they reported that they said, if you do the biopsy directly to the leg gadolinium enhancement, you're going to get a result of myocarditis in 70-80% of the cases. Then the same group has increased their numbers, and they haven't been able to confirm that. What they do confirm, though, is that if you biopsy both the right and the left, regardless of where the gadolinium enhancement is, you're going to get a higher yield.
One important thing here, which I would like to mention it as a note of caution here, is that in myocarditis, as you very well know, that there is a significant involvement of the mid-septum, which is not accessible to the bioptome. And also one of the very good studies from Bill Roberts, where it was demonstrated that more than 50% of time you have a localization in the epicardial regions. And if it is so, then whether we do MR or we don't do the MR, biopsy would be probably not possible, and we will have to depend upon the CMR diagnosis.
No, and I agree that that's probably what they found, that even though you have late gadolinium enhancement, it's in areas that you cannot access easily. So guiding the biopsy with the gadolinium is easier said than done, probably.
Yeah.
You know, one of the difficulties in studying myocarditis is that it's a relatively infrequent, or at least it's difficult to get a large case series, and certainly one that's well characterized. It would be useful to have some non-human animal model of myocarditis. Bill, where do we stand with that? What models do we have, and what do you think the future holds, or is that dead end?
So it's obviously a great question. I mean, being able to study the natural history of a disease in animals gives us a lot more for these kind of very episodic cases we see in humans. Unfortunately, the animal models have really not been all that helpful in terms of looking at prognosis or treatment options in humans. Probably the best, the two models are the Coxsackie B model in mice. The murine model works pretty well in terms of establishing the types of pathologic changes that Ari told us about, going from viral invasion of the myocyte to acute injury and destruction to autoimmune inflammation, cytokine release. I think those kinds of things that happen in the Coxsackie model, we think happen in humans as well. So in terms of understanding what the virus does and the innate immunity, I think the model helps. It doesn't really tell us much beyond that. It doesn't tell us why some animals will clear the virus and be okay, others will go on to die. Treatments that have looked effective in animal models have not proven effective in humans, which is an age-old story that we've seen in cardiovascular medicine for a long time. There's an encephalomyocarditis model that's a little bit less well studied that, again, replicates a lot of the early pathologic changes, but hasn't really been able to help us figure out who's going to develop progressive cardiomyopathy, or more importantly, who might respond to some type of therapy. So I don't see very much there. The field has kind of moved away from animal models at the current time.
And just to add to that, the model of Baughman and Neuberger, the one where they use the myosin, autoimmune myosin. So I think that's one other very important. So one gives us more of an autoimmune model, the other one gives us more of a viral model, but there is nothing which gives us both.
Right.
So
that's a good point.
So let's spend a few minutes talking about generalizing this to treatment now. We can talk about myocarditis. As we go through this, perhaps we'll generalize this a bit to muscle disease. But Radha, I have a series of a few case scenarios. Maybe I could get you to lead off. We're in a very practical way, we're presented with patients who come in with certain presentations. And then the question is, what do we do next? Okay, how do we work them up? So let me walk through with the panel a few of those. I don't think it really brackets the whole thing, but it has to do with acuity, how long has it been present, what's the real presentation. So let's just start with one. And this is now a patient who presents in cardiogenic shock, who is perfectly well until developing progressive dyspnea on exertion about 10 days before admission. So fairly acute. How should we start that, Radha?
Obviously, when the patient presents with about 10-day history of shortness of breath, that's fairly acute. So that a good history tells you whether this patient has myocarditis. Obviously, we have to rule out the other etiologies such as ischemic cardiomyopathy or myocardial infarction or coronary event. So the first thing I would do is to figure out what is the real etiology. As far as the patient is not in intermax level 1 and crashing on the floor, then I think the first thing is to rule out coronary involvement. Once that is ruled out, and if you don't have coronary artery disease, and if the myocardial infarction is not the cause of it, then the suspicion is what are the other etiologies. In that respect, if you take a good history, you should be able to figure out if the patient had any viral prodrome or any kind of infections prior to developing the symptoms. In the absence of such history doesn't necessarily mean that the patient doesn't have myocarditis. So the second step would be, after stabilizing the patient, is to an endomyocardial biopsy. And obviously, if that has been the practice, and the favoritism now is to do a cardiac CMR before we start intervention, so that the MR we are able to get an MR to get a much better idea of what the patient has. So the MR-directed biopsy is an option which, if we can do it, and if the patient's acuity allows us to do it. But in most of the time, when patients are Intermax 1, it's harder to wait and to have the MR done and then have the biopsy and then go in that progressive fashion becomes very difficult while you have to take care of the patient and stabilize them.
So, by the way, for those of you who aren't familiar with the Intermax classification, it's a classification that seeks to take people who are essentially class 4 patients and divide them up in ways that are clinically useful. So when he talks about Intermax 1 is basically the cardiogenic shock patient. Intermax 2 is an individual who's slipping on inotropes, or that would include actually circulatory assist devices. Intermax 3 is stable on inotropes, and so you'll hear it, and then it goes on up the line. The Intermax classification is very important to those of us who are dealing with advanced heart failure. So, Ari, that's I think in a general way, what we're hearing is that the first step is to hemodynamically stabilize the patient and then make a diagnosis. How would the approach after you stabilize the patient, do you think, join us and tell us what do you think the next step would be once you've stabilized a patient now who comes in with severe chest pain? I mean, how does the severe chest pain with ST elevations change the approach?
Well, I think, as Dr. Gopalan alluded to, the first thing foremost is to rule out coronary disease. And so, of course, the gold standard there would be a coronary angiogram. If the coronaries are normal, I think that assuming the patient is stabilized, this is one of the few instances where the ESC, the AHA, and essentially every scientific statement states that it's a class 1 indication to pursue an endomyocardial biopsy in the event that, or the concern being that you don't want to miss something like a giant cell, which may present very acutely. So I think first and foremost, it is ruling out coronary disease, and then secondly, once the patient is stabilized, if they present with hemodynamic compromise, it's pursuing the endomyocardial biopsy. One question that I had is that, of course, we always fear that we're going to miss giant cell myocarditis, and perhaps there is, you can interfere with the natural history of it by sort of giving steroids, probably sooner better than later. Are there any circumstances where you would give steroids in somebody who presents accordingly while waiting for biopsy results?
Bill, why don't you take that?
So I had a couple of general comments before we get to that. I think that, the focus on ruling out coronary artery disease in all of its varied manifestations is extremely important. We're talking about myocarditis today, but that's a zebra in real life CCU. Coronary artery disease is the top and bottom of the differential, and it can present in a lot of different ways. So certainly if a person comes in with LV dysfunction, even if it's global, and their EKG does not show ST elevation but may have nonspecific changes and they have a low-grade troponin, if they're diabetic or they have conventional coronary risk factors, you need to rule out multivessel coronary disease in that patient first and foremost. Certainly, you can have global LV dysfunction with triple vessel disease. We've all seen it. And not knowing that and treating this as a pure muscle disease is pretty much guaranteed that the patient's not going to do well. I think the issue about myocardial mimicry with ST segment elevation, we see that not uncommonly. Knowing that they don't have coronary disease, where you go next depends on how bad their LV function is. If they have MI mimicry but their ejection fraction is not particularly depressed, let's say 45, 50%, those patients are going to do well with conservative therapy. So you don't really need to do anything too aggressive other than sort of stabilize them. The issue about excluding, and the other issue is, trying a person that comes in with chest pain, hypotension, a funny echo, and ST elevation, you need to think about Takotsubo, which we seem to all have an epidemic of these days. It's everywhere. So it's certainly more likely that they're going to have Takotsubo diagnosed than lymphocytic myocarditis in most CCUs. So again, that's an easy diagnosis to make on left ventriculography or echocardiography, but certainly high on the differential in somebody that has chest pain, wall motion abnormalities, and normal coronary arteries. Getting back to the issue of giant cell disease and would you treat it empirically, I think it's important in the patient, when you present a patient like this with an acute presentation with cardiogenic shock, my thinking goes, three things. Rule out coronary disease or acute valvular disease, Takotsubo, done. Then you have to decide, is this likely to be an inflammatory process? Is it fulminant myocarditis, which is largely lymphocytic, typically 2 or 3 days, fever, shock, leukocytosis, often reversible with aggressive hemodynamic support, or is this giant cell disease, which is much less likely to, won't reverse just with time. And again, there are some tip-offs that are helpful. Fulminant myocarditis usually is less than 2 to 3 days, whereas giant cell tends to be more subacute, not weeks, but over the course of 7, 10 days. Giant cell disease usually has other evidence of infiltrative process, so that heart block is very common. Left bundle branch block, lots of ventricular arrhythmias. Those things are not really that common. In fact, they're rare with fulminant myocarditis, lymphocytic myocarditis. So if you have a patient that has a bundle or heart block or has lots of arrhythmias and shock, that's going to lean me much more down towards giant cell disease. The issue about empiric treatment with corticosteroids or other immunosuppressive agents is an important one. I think, to Ari's point, if I had a patient like this, EF 20% on a balloon, or maybe heading for percutaneous VAD to support them transiently, troponin, and left bundle, I would be thinking this person's got an aggressive inflammatory process, either sarcoid out of control or more likely giant cell disease. And I would give them immunosuppression while I waited for the biopsy to come back overnight. You don't really want to do that with fulminant myocarditis. So with fulminant myocarditis, there is a reasonable likelihood that there is still active viral replication going on because it really is an acute process. And we know from animal studies are helpful. If you immunosuppress animals that have active viremia and cardiac myocyte damage, they all die. So you don't want to immunosuppress a person who has active viral infection in the heart at the time. By the time we see people with cardiomyopathy with more traditional lymphocytic myocarditis, the virus is long gone. We're dealing with the inflammatory sequelae and the cytokines, so that treating that at that point is not deleterious. But in an acute lymphocytic presentation, you would not want to immunosuppress them.
There's a certain time delay that occurs. It's easy to talk about doing an endomyocardial biopsy, but by the time it happens and it really gets red, time elapses, and that, that's a problem. And somebody's acutely ill in an intensive care unit. If one is thinking giant cell myocarditis, it's really quite a rare diagnosis. Bill, how many have you ever seen?
This week?
Well, if it's that, you're a different institution than we are then.
So we probably see a half dozen a year, people transferred in very sick. My guess is that you probably have about that number that are coming into you, either recognized or unrecognized. It's less than a handful. It's very rare.
But if you have already made a decision of placing an LVAD, you basically will get the diagnosis anyway tomorrow when you get the core. So.
Okay. What about people who come in a bit later? Rado, let me come back to you. Okay. Now I'm going to present you with a patient who comes in with class 3 symptoms, now a 3-month history of progressive shortness of breath, but a dilated ventricle and reduced contractile function.
Well,
how does it work? How does the workup vary with this?
Well, I assume that we have already done an echocardiogram, so we have dilated ventricle. So that indicates remodeling of the left ventricle. So it has been going on for a while. Having said that, at this point, when in this patient, my differential diagnosis with regard to an inflammatory process will extend a little bit further, and I would not only consider myocarditis, but there are other components such as myopericarditis, perimyocarditis, and pericarditis. They are all part of the inflammatory process of the heart. We don't talk about it all the time, and I would incorporate them. Obviously, electrocardiogram is going to show us the characteristic features of pericardial involvement, and the echocardiogram might show us the effusions and other features of those. So it increases the number of differentials I have at that time. Clearly, if the patient is naive to medications and has not been treated, then obviously, personally, I would do an endomyocardial biopsy to look for to confirm myocarditis, and then initiate treatment. When such patients present, and if it is in fact myocarditis, if you are able to make a diagnosis, then obviously the treatment is directed towards how they are going to behave. And the literature shows us that, as Dr. Deck explained, was when somebody presents with fulminant lymphocytic myocarditis, they appear to have a good prognosis, especially if their left ventricle has not remodeled and the wall thickness is preserved. They, in fact, almost normalize. In most of this literature indicates that they normalize ejection fraction and function, as long as the conventional therapy is not aggressively instituted. In fact, the indication is that you should utilize all the neurohumoral attenuating medications, but you should take it a little slower than you would normally do, and don't go aggressive on neurohumoral attenuation. So I would do.
Yeah, go ahead.
I would do workup to make sure that you figure out whether you're dealing with myocarditis, myopericarditis, perimyocarditis, or pericardial involvement, and then tailor the treatment.
So I agree with all of that. I guess I would, just since myocarditis is the topic for today, it's important to place this to your question, how much giant cell did you see versus other things? I would view this person that you presented 3 months of heart failure symptoms, echo shows low ejection fraction, LV dilation. That's an acute dilated cardiomyopathy. I know you were steered towards myocarditis, but don't be steered towards myocarditis as the only diagnosis. You need to keep a broad differential. If this is a new cardiomyopathy, you can go to Brownwald's textbook and there's about 118 things that are listed as causing a dilated cardiomyopathy. You need to have a broad differential for that. And so things that I'm thinking about in addition to myocarditis, which is obviously something that I think about a lot, is this a familial cardiomyopathy? Get a good family history, okay? Cousin died at 35 of sudden death. You may want to do some skeletal muscle testing, strength testing, see if they have any evidence for skeletal myopathy that would suggest a genetic component. So think about genetics, think about myocarditis, think about toxins. A very common cause of dilated cardiomyopathy is alcohol. Not alcoholics, but people that have a couple drinks a couple times a day. We all see that. It's underdiagnosed. It's completely treatable and reversible if the diagnosis is made and people stop drinking. So, keep a broad differential. Coronary disease we've talked about already. You're certainly going to want to make sure that they don't have occult coronary disease or valve disease. But, I think genetics, environmental factors, and other things are important to not miss when you have that new patient.
Okay, well, let's turn a little bit. We've talked a little bit about genetics. Let's talk a little bit about treatment and genetics, if we could. The central paradigm, and I'm going to generalize this a little bit from myocarditis to muscle disease generally, but certainly a central paradigm of treatment is neurohumoral antagonism. That is, antagonizing the biologically active molecules that are released in the setting of heart failure. Some people respond well, and some people seem not to respond at all. We've certainly seen, as I briefly asked you at noon, we've certainly seen indication that, for instance, blacks don't respond well to ACE inhibitors and beta blockers as a group. Presumably there's a genetic basis, maybe not, but that genetic basis, if it's there, may in fact exist, although with lesser penetrance, if you will, or lesser frequency in other races. Do we have any chance, do you think, in the foreseeable future of defining a genetic basis for response to the therapies that we're assigning for neurohumoral antagonism?
I guess I'll start with that. I'm certainly always optimistic about the future. I'd like to believe that we will do a better job at defining personalized therapy based on what the individual's genotype and phenotype is. Right now, heart failure therapy, as you alluded to, is a black box. We throw the same drugs at everybody. Sometimes they work, sometimes they don't work. We don't really know why. I think that certainly we are not as far along in the heart failure and myopathy world in looking at specific genotypes and trying to correlate who's going to respond or not, as perhaps our platelet antagonist friends are, or the Coumadin genotyping crew, and even that's been somewhat difficult to show effectiveness in some settings. So I think we need a lot more information. Certainly genome-wide association studies are being done everywhere. We're really understanding genotypic variation more. A lot of the studies that we are doing and others are doing are now trying to look at panels of genes, looking at what are upregulated or not in cardiomyopathy, and hopefully we'll have some signals there. I mean, the two that we've looked at that I showed you today, you know, one variation in the beta receptor and one genotypic variation in ACE did not really predict recovery of function like we thought they might, but we have another half dozen that are in the pipeline that we're looking at. So I think we're at least a half dozen years away from that, maybe longer, but it's certainly an important avenue. I mean, I think the issue just of, you know, race and gender in treating heart failure, we haven't even scratched the surface. I mean, we think that women behave equally well to most drugs, but there haven't been a lot of comparisons. They've all been sub-studies of larger studies, and certainly the African Americans we know don't respond to the conventional agents nearly as well as we thought they would. So there's a lot there just looking at very simple factors too that we don't understand.
Can I ask anybody else from the panel to add to that?
I mean, I think Dr. Deck said everything about it, because as far as the ACE polymorphisms like the DD and ID and II is concerned, or the beta receptor polymorphism is concerned, or alpha-2C polymorphism is concerned, whatever they are, I think they have really not panned out the way we had thought, specifically when you look at the BEST trial or bucindolol trial or its aftermath. It basically hasn't worked out the way we thought initially. And again, we are still restricted to the gender. Whether the RNEs that was presented by Dr. Fuster this morning, I mean, it will be working only in Caucasians, probably not in the African Americans. On the other hand, the bidel type of a thing would probably do much better in the African Americans as compared to anything else. But I think a lot more needs to be done in terms of larger number of polymorphism or larger number of genes, whether we are focusing on something very simple at that point in time. I think we need to go much beyond that, and Bruce Gelb is here. I think probably he would be able to give a better answer to that. But I think we really need to go much wider than what we have done. We just focus on one single small polymorphism, and we think that it is going to result in something big. I think we are mistaken.
So let me look. I'm going to ask you one more question, and I'm going to open this to the audience in the last few minutes and see if there are questions from there as well. But now, in terms of treating muscle disease, for all the talk about genetics and various mechanistic things, in the end, what's been most effective for us, at least to this point, is replacing lost function. No question that when we just remove a heart and put in a new one, when we do an allograft, we really get good results. Unfortunately, there are only about 2,200 of those available in the U.S. every year, and that's a tiny fraction, way under 5% of the group of people who could use it. Cell-based therapies are a story to be told, but there's a great deal of science that one would need to elucidate to actually use that sort of thing clinically. In fact, there's a great deal that we don't know, to paraphrase our former Secretary of Defense. Mechanical support has come a long way, and in point of fact, one might argue that mechanical devices, a family of LVADs, RVADs, total artificial hearts, depending on what one's personal need was, that are durable, fully implantable, and practical, might in fact be a solution to a problem that may be more effective than some of the other approaches, these elegant genetic approaches. I'd like to hear the panel expound on that a little bit. Look into your crystal ball for me for 5 minutes and let's hear about it. Bill, why don't we start with you as our guest?
Okay, sure. So I agree that stem cell therapy is definitely way in the future. We don't understand a lot of the basic concepts like which cells, how many, how do we deliver them, how do we keep them alive. I'm a little more optimistic about gene therapy, particularly some of the work that Roger Hajar has been doing. I do think this whole upregulation of sarcoplasmic calcium ATPase has a lot of potential. It's worked well in animal models. It's shown safety in clinical models. So that's probably 5 years down the line, maybe a little less, maybe a little more. So I do think gene therapy is going to have a role. I think in the immediate next 5 years, the best thing we have is mechanical support. We know it works well. There are a number of problems with mechanical support. A I'll just list a couple. It's extraordinarily expensive. And so if we pull it off the box and put it in 100,000, 200,000 people dying of heart failure every year, that's a huge healthcare expenditure that we've not budgeted. Not sure how we're going to pay for it. I think that the pumps that we have right now are not foolproof. If you can get 2 years, 2.5 years, 3 years, maybe a couple years anyway, before it fails or you have to change it out, that's good. I think we need pumps that will last at least 5 years with a failure rate less than 20%. So that if you have a good engineer and they can basically design a pump that will last 5 years or more, it's probably going to be cost effective. And then the final frontier is obviously getting it totally implantable. I mean, to have drive lines coming out of your chest and battery packs is not conducive towards a normal life, and obviously increases the risk of infection quite significantly. So I think that there's some technical things, making batteries smaller and better, implanting the device, and then making it less expensive. So those are the barriers. The opportunity is we have really good engineers, and the pumps that have come along in the last generation or two are so much better than anything that's ever come along before that I think we're almost there, that it could be much more broadly applied as destination therapy, but I'll be interested in others.
Jagat?
I think I agree with Dr. Deck, but if I have to bet my money, I would certainly bet on the mechanical devices. And I think these Jarviks, Terumos, or ECATs, they are the way to go. And I tell you, I was personally in friendship with the first person who got the first Jarvik, Peter Houghton, in Oxford. And he survived 6.5 years. The man was green, 21 bilirubin when he was waiting for the transplant, and had the blood group which was not letting him get the heart, and ended up getting Jarvik and survived 6.5 years. Came 5 times to represent to FDA in favor of the Jarvik pump alone, flying from England to here. So I think in my opinion, probably I think we really have to focus on that. That is something which is going to get us much farther, much faster.
Radha, why don't you tell us?
Yeah,
what you
a
think?
couple of comments, and I think it appears that the survival outcome basis, irrespective of the etiology of the myocarditis, since we're talking about myocarditis, it appears that when you clinically take care of the patient, there are 2 things in the literature that points to how patients are favored or fared. As if they have fulminant myocarditis, they seem to get better. Columbia published a paper last year about mechanical support devices in patients who are in Intermax 1 with fulminant lymphocytic myocarditis. Biopsy proven, they implanted 11 devices, 3 of them were ECMO and 8 were Centrimac BiVADs actually. And within 2 weeks to a month, they were able to explant the devices with full recovery of the left ventricle. So that is, at least in that setting of fulminant lymphocytic myocarditis, the LVADs, those intermediate term LVADs such as Centrimac and ECMO, which is fairly shorter than Centrimac, seems to at least support the patients while they are healing and the ventricles are recovering, especially in those who have non-dilated hearts with a fairly preserved thickness of the walls. The second comment I have is that whether those devices can now be either replaced with the even shorter term devices such as a 5-liter impeller with the cut down method, which is a much more easier procedure to do than implanting a Centrimac, remains to be seen. I haven't heard of anybody utilizing it in that respect, but I would like to ask Dr. Deck, what is your experience with the lymphocytic fulminant myocarditis?
I think our experience is somewhere in between. I mean, the McCarthy paper in New England Journal that showed a 90% survival, pre-LVAD, I mean, just with balloon pump, is sort of the best case scenario. There's more recent studies that suggest more like 60% recovery. We're somewhere in between. I think probably 70% of our folks with acute fulminant actually, if they're supported, they do get better, and they go home with pretty good LV function or normal function. So that group, I think, is salvageable with relatively short-term support. I think your idea of using, these higher flow impeller devices, perhaps, rather than a full pump, might really open the field up a bit more.
Okay, in this last 2 or 3 minutes, I'd like to open this to the audience and see if there are questions that we can take from there. Please, if you would, come up to the microphone, or maybe, I don't know if we have anyone to bring it over, but...
Just a quick question about the ACE inhibitors and beta blockers. Any thought about the use on the long term in patients with myocarditis? ACE inhibitors and beta blockers.
Okay.
Any evidence on their use, systematic use in patients with myocarditis?
So the question is, are there evidence about the use of ACE inhibitors and beta blockers in patients with myocarditis? In terms of, are you talking about the acute phase, early phase, or long-term therapy? Okay. So it's a great question, and I guess I would broaden it a bit more, since, you know, for patients with acute dilated cardiomyopathy, forget myocarditis. If you have a patient, and we all have these patients, fortunately, who have a low ejection fraction, they normalize their function. Their heart is completely normal by echo. And again, we can do MRI now and look to see how much scar there is, and we actually haven't done that. But there are no randomized trials about keeping people on drugs versus stopping them. I think that most of us who do this work and take care of cardiomyopathy patients have all seen patients that relapse if you wean them off all of their neurohormonal antagonists. So I generally, again, purely empiric, if somebody normalizes their function, I will do a stress echo to see if they have any abnormalities that are brought out with exercise, suggesting a residual low-grade cardiomyopathy. I also might consider an MRI, looking to see how much scar tissue they've got or not. If they have good reserve and not much scar, I will usually wean them down to one drug over time if they've had at least 2 years of normal echo. I think other people do it differently, but I don't totally strip them. I mean, the only person that I would typically take off of drugs who had a cardiomyopathy is somebody with alcohol-related cardiomyopathy who stops drinking. And I personally take peripartums off all their drugs if they normalize their function. But I know that others disagree, that say that that's not a good plan.
And just to support Dr. Deck's opinion here, if you go by the ACC-AHA guidelines, once in Class C, you are always in Class C.
Ray, we're going to give you the buzzer question, okay? This will be our last question.
Just wanted to open it up with mechanical support. What is the appropriate or best means to assess for myocardial recovery in a patient with myocarditis who you suspect has ultimate recovery?
I'll let you take. So, you know, the question is, if you have a person that is on mechanical support with an acute viral myocarditis, you think they're getting better. So obviously you need to look at their heart by echo when they're fully supported. Is the heart working well? Is the heart decompressed? Wall thickness should be normal. And then you start doing ramp protocols to start backing off. And I don't do that anymore, so I'll leave it to the experts to describe how it's done. But you obviously need to start loading the heart by decreasing the amount of pump and then see what happens. But there may be more formal. I don't know what your protocol is here for.
Personally, I think the first requirement is echocardiographic criteria. The patient should have recovered normal function. So if the initial ejection fraction was 30% and it comes up to 40 or 45, we don't think about explanting the device. That's not full recovery. It has to be 55 or above and become hyperdynamic with the support. And you're able to wean off the inotropes and you also have to look at the RV function if they had biventricular function, if they're on biventricular device. So both of those. And then the next step, if it is normal and if you are able to successfully wean off the inotropes, then the next step in an acute care setting in the intensive care unit is to reduce the RPMs of the device and then observe the patient with reduced RPM and see if the heart is supporting adequate cardiac output. And the way normally that I'm used to doing it is in my previous institution is we have a Swan-Ganz catheter and that is monitoring cardiac output continuously at the time you reduce the RPM. And that way you get the hemodynamic information in real time so that you know what is really happening rather than relying on the clinical set of information such as urine output and blood pressure and things like that.
All right, well, thank you very much. Very interesting discussion. Thank you for joining us, Dr. Deck.
My pleasure.